although people joke about being a little OCD, obsessive compulsive disorder is in fact a tormenting condition. The good news? There's help that works. Find out more about obsessive compulsive disorder tonight on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. So last night I'm ironing so I don't look rumpled in your living room, and as I head upstairs I think to myself, did I turn off that iron? So I go back down and check. We've all done this, right? But tonight we're talking about what happens when that thought and that behavior go a little haywire like it does in obsessive compulsive disorder. And we're going to be answering your questions throughout the show about obsessive compulsive disorder and other anxiety disorders too. So pick up that telephone and call the numbers on your screen locally. Dial 218-788-2844 or call toll free at 1-877-307-8762. You can also text us your questions or email them using the number or address listed at the bottom of your screen. We're going to start by introducing our guests. Dr. Charles Orsak is a licensed psychologist with Onset Health who specializes in the psychological evaluation and treatment of children and adolescents. He has a special interest in the treatment of obsessive compulsive disorder. And Dr. John Glick is a board-certified psychiatrist who's been with the Human Development Center since 1991. He works primarily with adults and has an interest in complementary medicine. Thanks to both of you for being here this evening and foregoing the vice presidential debate. So I feel honored that you're here. I'll bet that was a tough choice to make. So
yes, we'll try not to do a Joe Biden.
A Joe Biden
yes,
Joe?
Yes.
Or a Joe Biden?
Biden, yes.
Don't do a Joe Biden.
Yes.
We're a family show. So we're going to talk about obsessive compulsive disorder. And since you primarily work with kids, but maybe before we get started, let's just get everybody on the same page and start first by describing what obsessive compulsive disorder is, and let's talk about the obsessive part of obsessive compulsive disorder first.
Well, there's two parts. The obsessions refer to the thoughts and feelings that people have. So an obsession is an intrusive, very distressing, anxiety-provoking thought that the person most of the time realizes is off. They realize that it's not a real thought and there's something wrong. They want to get rid of it desperately. And then the compulsion is the behavioral piece where they do something to sort of relieve that anxiety to undo that. So for example, if the obsession was about contamination and germs, it would be that I can't touch that cup or I can't touch that doorknob because of the germs, even though I've washed my hands once. I wash my hands again and I feel better for a little bit, but then quickly the thought comes back and I end up repeating that cycle over and over again. So it's a cycle of thoughts and feelings and behaviors.
And the obsessions can come in sort of a number of different categories. Dr. Orsak named one, which is this fear of contamination. Give us some examples of other categories that these obsessions tend to fall in.
Well, first of all, it's important to note that the obsessions sometimes occur as images or pictures, and then we have to differentiate that from schizophrenia. That's much different than a hallucination.
So that it's not necessarily just a thought. It could just be an image that you have in your head.
Or a picture.
And how do you differentiate that between and hallucination?
Well, people with obsessive compulsive disorder know that their mind is producing the picture, whereas with schizophrenia, it seems like it's something real and different from the person. And some different categories. A common category is aggressive thoughts. I've seen over the years several grandmothers who have held a secret for many years of having had these embarrassing thoughts that they might kill their children or grandchildren. It's a what if I did, or what if I hurt myself? So
they're
aggression
not really,
towards self or others is a common theme.
They're not really at risk for hurting these other people. It's more that they're afraid that they could be doing this.
Right, and they feel very embarrassed to have this thought towards somebody they love, and very confused. Also, forbidden and perverse sexual thoughts or images is common. Charlie, you mentioned contamination, counting obsessions, repeating numbers, repeating songs in your head, symmetry obsessions, thinking things a certain number of times or having to think things a certain way. There's a lot of different. Can you think of other categories?
That covers all the categories.
Or that sense that something is unfinished, that I have to go check something to make sure that I have done the right thing at the very end, like I've unplugged that iron, or I've turned off the water if I'm going out. Those kinds of finishing tasks as well.
It's called pathological doubt. And somebody with that problem might, for example, check doors when they leave the house to be sure they're locked. They might head out on vacation, be 100 miles down the road, and have to turn around and come back to check the door to be sure they actually locked it. So it's just, you can't let it go. What if? What if I left it open?
And I think one of the things I try to help the kids see is that we all have these thoughts. And we all have our little idiosyncrasies. We might check the lock 3 times. We might have some kind of doubt, or we need things in order. We need control. But in OCD, it gets stuck like an old-fashioned record playing over and over and over and over. And that's the tormenting part. Because most of the kids I work with desperately want it to go away. And that's one of the distinguishing features is it feels very, they get the sense that it's something alien that's...
Because when I go to check to see if I unplug the iron, even if I go downstairs to check and now I'm preoccupied with something else, and then I go back up the second time and I go, oh my gosh, did I even check to see? I can remember that I went down, and that's enough for me. And now the thought's out of my head. Like the fact that I went back downstairs, I'm positive I checked, I'm positive that means that the iron's unplugged, and I feel reassured and I can move on, and the thought's no longer in my head. But in people with OCD, tell us how that's a little bit different then.
Well, it's that feeling of, sometimes it's referred to as pathological doubt. Maybe I didn't, or what if I didn't? Another form is, having to do things in a certain way, having to get dressed in a certain sequence, having a ritual in the morning for grooming that has to go in a certain way, and if you get interrupted, you have to start all over and do it again. And that's called a completion ritual. You were talking about the checking rituals. People check outlets, they check stoves, they check doors, those types of things.
And those kind of behaviors wind up not being really reassuring in the long run for the person.
Well, one thing that we think might be going on is that the part of the brain, that kind of in the central part of the brain, that has to do with sort of ritualized and patterned behaviors, is supposed to be connected to the cortex of the brain, which is sort of your rational thought. And there may be some disconnection there. So the part of your brain that says, okay, the rational part of my brain says, I've checked the iron, it's okay. If there's a kind of a disconnect there, all you have running is this sort of ritualized behavior. So one of the features of OCD is it doesn't make any sense. Reason really it doesn't do much good in trying to understand. Because he'll say, I know I don't need to wash my hands again. I understand, my logical brain knows that, I can't, but I feel like I have to do it. So it's not a matter of reason and logic. And so it might be a disconnect there.
I describe it sometimes to people that it's like your brain has an itch, and the only way you can scratch it is by engaging in this ritualized behavior. And we all know what it feels like to have an itch, right? You want to scratch
an itch
it.
That won't go away.
Oh, an itch that won't go away. This occurs in kids.
Yes.
Tell us a little bit about age of onset in kids, and what would parents notice?
Well, it's in children, it's more common in boys. And the typical age of onset can be anywhere from 8 into adolescence. It can occur early in girls, but it's more typical for girls to be adolescents and young adults. And by the time people are young adults, the rate of OCD is about even between men and women. And so a lot of time it's boys, they present often with multiple kinds of obsessions. So it won't just be kind of contamination or doubt or order, but it might be a mixture of those things. Kids tend to keep it a secret, and they try to hide it. And usually what happens is people notice the compulsions, the hand washing or the sort of touching the walls in a certain way. And kids finally say, yes, I'm counting. And invariably when I talk to kids, there's more than one thing going on. So they'll be counting to even numbers always seem to be something that people prefer. It's usually even, not odd numbers. Then they have to count steps, or they have to turn off the light switch in a certain way. So.
And adults try to hide it too. Often the thoughts are associated with shame or disgust or feeling like you're crazy. It's called the hidden disorder. It actually affects 3% of the population, but it's often not diagnosed till people are much older. If it's not picked up in childhood especially, then it often goes underground.
And one of the things that sometimes happens with kids is you'll say, by the way, do you often have thoughts that you think are really scary and frightening and you can't do anything about it? And they go, yeah, how'd you know? And you say, well, that's because that's what happens. And there's actually a lot of relief just in knowing that it's part of.
That's a big part of the treatment is education, just knowing what's happening to you and that you're not crazy, that it's that education is the first part of the therapy process. So.
And what a relief that would be, right? Especially if we're talking about an adult where that was able to go, they managed for that to go underground, and having that sense that I just feel like I'm kind of losing my mind here. I feel like I'm going crazy. I feel odd. I feel different. I don't want to be that way, but I don't know what to do. And nobody wants to have verification that you're crazy.
Right. So if you look at, there's probably 1 out of 100, 2 out of 100 kids that have OCD. So you can point out to kids, there's 600 kids in your school. There's 4 or 5 other kids that have this as well.
Just like you.
Just like you.
We have a question here from a woman in Duluth who said, if my OCD isn't hurting anyone, do I need to get treatment? Dr. Glick.
Well, it's a decision that for treatment is based partly on how distressed somebody is by the symptoms and partly on how time-consuming they are. And partly on how much they interfere with a person's life. Do they interfere with your academic or work or social or recreational life? So it's distress, it's impairment of functioning, it's how much time does it consume. You add those things together and you can usually make a decision. Different people have different thresholds.
And certainly I've seen people who've been able to maybe manage their OCD. They have it at a level that they don't want to get it down any further than that, and it's not interfering with their ability to. They can get out the house. I can check the door 10 times and still get to work. And so it's not interfering with their life, and what's brought them in is a different problem. And we happen to find out that they have this funny thing that they do, but it's not interfering with their life. Other people we know, and with kids, you said that it's most likely to be witnessed, that the compulsions are most likely to be witnessed by other people. How is the presentation maybe different at home versus in school?
At school, I think kids put a premium on not looking different. So I think that, so they're able to, you can do your counting secretly. And you can use your hand cleaner kind of surreptitiously. And so the pattern that I've seen is, though, that when they get home, they sort of have to do it more. So they kind of hold on tight during the day, and then they get home, and then they do a lot of rituals at home.
Now, I would just guess that if you've got all of this stuff going on in your head, though, at school, that's going to make it's hard to pay attention. And so maybe how part of the unraveling of the problem in the child is not just the noticing of the compulsions, but maybe not achieving at school the way you might expect your child to achieve.
Right. then they'll be sort of distracted by all these inner thoughts. Now it's a pretty good co-occurrence of OCD and attention problems and tics. Those things kind of go together. So, and tics would be those abnormal sort of facial movements. So,
other things that would
those
bring
tend
the
to go
problem to
together.
light
Right.
as well.
In other words,
Right.
if you have OCD, a real high chance of having ADHD or attention deficit
And
disorder.
Tourette's, yeah.
It doesn't always work the other way around. If you have attention deficit
Right.
disorder, you usually don't have OCD.
Here's a caller from another woman from Duluth calling in. Is it true that a virus can cause OCD in young people?
Well, sometimes a strep bacterial infection can trigger obsessive compulsive disorder symptoms, and the setting there would be a youngster that's sick and has a fever and suddenly develops obsessive compulsive symptoms. You usually end up probably treating it the same way, but if it persists.
And a man from Esco is calling in. Do kids in dysfunctional homes suffer from OCD disproportionately?
No. There's a strong genetic component in OCD. If you look at say a family, if you have a family member with OCD, there's a fairly high rate of or fairly high chance that other people will have that. In identical twins, there's a very high rate of co-occurrence. Now, what I will say to the gentleman's question is that sometimes kids compensate for stress by getting kind of obsessive about things and compulsive behaviors and
Rigid.
control. So they get to, I wouldn't call that obsessive compulsive disorder, but there are obsessive compulsive behaviors that sometimes kids will try to use to cope with stress. But we would treat that differently, because it's essentially, the idea would be if we get rid of the stress, we help the child with the stress, those symptoms will go away. Because kids can have OCD from any kind of family.
If you have OCD, though, does stress make it worse?
Sure, I think that's true for many different, mental illnesses.
And physical illnesses
and
too,
physical
actually,
too.
right? Yeah.
Yeah. And people with OCD often have other types of anxiety associated with it. And people that get depressed often develop OCD
Right.
symptoms that they don't have when they're not depressed. So yeah, you can see a lot of different variations.
Let's start talking about treatment for obsessive compulsive disorder. What do you do to help a kid?
Well, there's some accepted behavioral and cognitive treatments, and that simply means teaching kids how to behave and think in different ways. And the sort of technical term for the procedure is exposure with response prevention, but basically all that means is we try to teach the kids that they can change their thinking to do the opposite of the obsession, or do the obsession or think differently, and do the opposite with the compulsion, or do the compulsion differently. So sort of the classic idea would be, if I can't touch that cup because it's contaminated, we'll do a little bit of slowly, gradually getting up to the point where we're doing that more and more and more and more and more. So we give the kids some coping skills with relaxation so that they can tolerate it. But the approach I use, actually the workbook I use, is called Talking Back to OCD, which is sort of we take this assertive stance. And one of the first things we do is we name it. We give it a name. The child gives it a name, and it's usually not that nice a name. But the idea is being that we want to make it. We try to help the kids distinguish between their thinking and the thinking of the OCD, because we don't want them to think that that it's bad. There's nothing inherently wrong with being anxious. I mean, anxiety is a very important part of staying safe in the world. So we're not trying to shut off their feelings. We're trying to target these very specific obsessions and compulsions. So it's a matter of kind of the kids come in with a notebook, and we come up with assignments, and they go out and they practice. And it's a family approach. So the parents are really coaches, and so they take part in all of this. So for example, it will be, well, one of the interesting ones is is this neatness. And so some parents will wonder why we're treating this, but some kids are compulsively ordered and neat. And so one of their homework assignments will be to wad up paper, right? To wad up paper and have a messier and messier and messier room until they can tolerate it, until they can have a normal teenager's room.
And parents think that's a good
Yeah,
idea.
and they
the
take a
moms
second
are,
look
right,
and they talk about that. No, in all seriousness, though, that is not. But here's the thing about it. It's a great example, I think. If you talk to the kids, they don't enjoy it. The neatness part is a burden. I mean, if something's out of order, it's really distressing. And the idea that their little sister went in there and moved something really, really, really bothers them.
Because sometimes the
yeah.
moving that we're talking is by moving this cup.
Oh, that's
like
way
that.
too much.
That's way too much.
You have to, yeah. No, you have to put it back.
And you have to put it back.
Right. But that's once isn't enough. I probably have to do it several times to get it just right. So.
See.
And that's we're doing therapy right here.
Right.
Thank you.
Yeah. Medications in the treatment of OCD.
Well, I just wanted to say on the therapy, I mean, we do treat obsessions and the compulsions a little different. And with the obsessions, one of the important things is not fighting the thoughts so much and just welcoming them, letting them be, labeling them, noticing them. Sometimes people will think of them as junk mail from the brain.
I like that, junk mail, spam.
Yeah,
Right.
yeah.
Brain
yeah,
spam.
You didn't ask for it, you don't want it, you're not quite sure what to do with it, but you got to deal with it. But it's that education component that instead of trying to hide from the thoughts and ignore them, maybe just use mindfulness and let them in. In terms of the medications, the serotonin boosters are often helpful. Prozac, Paxil, Zoloft, Celexa, Lexapro, the same types of medications that are used for depression. Those serotonin boosters also treat most anxiety disorders, including obsessive compulsive disorder. Sometimes we have to use doses that are higher than we use for depression. But that's the main treatment.
And depending on the severity, use a combined treatment of cognitive behavioral therapy and medicine.
And medicine. And medicine in kids, too.
Right. It depends. It's always a parent's choice and the children's choice. But if it's mild, if it's a mild form of OCD and we can possibly treat it, mild to moderate, we can treat it just with the behavioral therapy, fine. But if it's incapacitating, and it's really having a serious effect on the child's life, then a combined treatment.
And certainly with some adults who are not maybe getting treatment until this has been more of an entrenched problem, then it's going to be difficult even to just have therapy alone, and for that to be effective, maybe the medication and the therapy together are going to be the best option, I would imagine.
Yeah, maybe. Every
maybe
case is so different and individual, but behavioral therapy often, the response is often better than with medications. If you compare the two alone, this group on meds only and this on therapy only, you often see a better response over here, but you often get the best response with both of them.
Because it tends to persist, and so a lot of times what we do, we try to give the kids enough skills so that they can recognize it when it pops up again. In fact, I use the whack-a-mole analogy, that game, saying if it ever pops itself up again, you know what to do. You do the opposite, you do it differently. You're not afraid of it. And like you said, it's supposed to be this really frightening thought, and you say, no, it's junk mail. And that's thinking the opposite of what the obsession wants you to think.
Yeah.
And so we just give them the skills to sort of lay out this simple way to address it, because sometimes it does morph itself, pop itself back up. But usually they can handle it.
And even in my work with athletes and my work with sports psychology, we talk a lot with anxiety that people have in performers of inviting the anxiety in rather than fighting so hard against it. And that will just take the power away from the anxiety. And that's what I'm hearing from both of you tonight. The same with obsessive compulsive disorder. Do the thoughts actually ever go away, or are they tolerated better?
I've seen both happen.
Either or.
Either or.
So, which I like that concept, because that means that the thoughts don't have to go away in order to get
well,
better.
getting back to the person's question, I mean, if you check if you check your door 5 times at night, who's harmed? I mean, you can lead a full and happy life and check your locks 5, 6, 10 times a night.
It's very characteristic for the types of thoughts and the types of symptoms to change over the years.
Yep.
Washing, checking, more common in childhood. aggression and sexual type symptoms then becoming more common in adolescence and early adulthood. But it's a waxing, waning disorder, one symptom coming in and going out and another one coming in and going out over time.
And that's it for tonight. We're done. We're out of time. We're out of time. And so what did we learn tonight? We learned that obsessive compulsive disorder is common in both kids and adults, 2 to 3%, with only 10% of the people with obsessive compulsive disorder actually getting treatment for the problems. What you also heard, though, is that treatment can be very effective, help you be more functioning in your life. So if you are struggling with obsessive compulsive disorder out there, don't be struggling anymore. Call someone and get some help. Thanks again to all of you for being here and to our guests. Don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of our topics and resource links and read my blog, the place where I answer more of your questions. You can also email us your questions about next week's show, when we'll be talking about helping kids succeed in school. Who doesn't want to do that? I'm Dr. Carolyn Phelps. Thanks for watching and good night.